Hey, Dr. Clearfield, Chris here.
Hi, Chris. How are you?
I am doing well. My camera is not working. I
Great.
have had a barracuda of a day.
Hmm.
So let me share my screen. Bum, 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 bum. There we go. And I understand you're traveling, my friend.
Not tomorrow.
Oh, tomorrow. Okay.
Yeah. I'm going to AMMG in Miami, and I think A4M is this weekend also.
It is. Now, I remember being at A4M lecturing at all the conferences, and then AMMG came along and lectured there a couple of times. So,
Uh, so I used to speak at A4M, and then the gal who used to invite me, she left, and they haven't asked me back since. So, but
well, they're lost. They're lost.
it is their loss. So AMMG has me. I for this is like the 10th or 11th straight session where I'm the last speaker. I'm the first speaker and the last speaker.
Okay. Well,
So,
you're the cleanup batter.
well, we run our own conferences, and one time I was at credit hours short, so I had to jump in real quick. So I told everybody I was saving the best for last. So that's what I tell them. But so I always dedicate the last lecture. I call it the Johnny Castle Memorial Lecture.
Okay, there we go.
You remember who Johnny Castle was?
I know Johnny Castle.
You know Johnny Castle?
Was he not in? Tell me if I'm wrong. Either Reno or Nevada. Am I wrong?
No, not that.
Johnny Castle. Then no.
Anybody else
There
out
was
there know who Johnny Castle was? Joel, I know you know, so you don't remember? So let me give you a hint. Nobody puts baby in the corner. Does that help?
Nobody puts baby in a corner.
Yep. Does that help? Here's a hint.
Some hint. Shoot.
It's a good hint. Somebody in the audience always knows.
Right? Johnny Castle. Johnny Castle.
Johnny
Johnny
Castle,
Castle.
right? So I'll leave it there. We'll leave it as a quiz.
And I'm not going to Google it.
Yeah, don't do that. That would be cheating.
That's right.
well, I'm
Okay.
in the process of cheating, just so you know.
Are you process of cheating? Anything come to you,
I'm in
Chris?
the process of cheating. I would be a bad cross witness if I put my hand on saying I will hereby. Oh, I okay now. Okay, I get it now. Yes.
But you get it. So, but do you get why I call it that?
I don't know that part. At least I now know who Johnny Castle is.
Yeah.
I mean, you're speaking from Dirty Dancing? Yes.
There you go. Yeah.
Hmm.
Okay, that's an additional clue for everybody.
Yeah. Dirty Dancing.
Should have known.
Yeah,
It's
Right.
funny.
So
yeah, yeah.
every good character needs to have in a story what we call a white hot imperative. That thing that you got to do. Sort of like your main points in your talk here tonight.
Right?
Oh my goodness, there's expectations like that. Oh boy,
Mm.
now I'm getting stressed.
So, what was Johnny Castle's white hot imperative throughout the whole movie? What did he have to do?
I don't know if I ever actually watched the movie, so I can't speak to that. I
Uh,
don't get out much, my friend.
the movie's 25 years old. I mean, the guy's been dead since 2009.
Right? Jeez. White hot imperative. Well, it obviously had to do with dancing,
Obviously, right?
right?
So I'm going to assume he's not going to be sidelined or something. I have no idea.
Well, that was
Right.
the bad guys tried to sideline him throughout the whole movie.
In 1987 was that movie.
Yeah, it was a long time ago.
A long time ago.
Oh, it
I
doesn't
was
seem
in high
that
school.
long. Actually, it doesn't seem that long ago. I can still remember 1987.
I was in high school at that time.
Yeah, I graduated high school in '84 myself. So
Did you? Okay.
graduated college '88. Naturopathic school '92.
Nice.
You're
Nice.
just a baby then.
That's right.
I cried like one too. I guess I wouldn't want to be put in the corner either.
So yeah, so I gave a talk a couple of weeks ago on about low dose naltrexone,
Right.
and it was developed in 1985. That's when it sort of came to be. So I started the talk with I went and looked up. Those cards you see like in a card shop. You were born in 1957, and what the price of what was the most
Oh
popular
yes,
car?
yes, yes.
So I went and looked all that up. That's how I started it. So what was the most popular car in 1985? The best selling car?
Ooh, I'm gonna say Mustang.
No.
Oh, I'm gonna say some sort of.
Yeah, it was a Chevy Cavalier.
That's what my wife had. She had an '88 Chevy Cavalier.
No way.
Uh-huh.
Yeah. The average price home in Reno was 70 to 90,000, and a Corvette cost $24,403.
Right.
And our first house we bought in '93. It was a 1,543 square foot house, 1,543 square feet, $119,000, and now
Wow.
its value is $545,000.
Yeah, I know.
Jesus.
Well, we all have that. So yeah, my
Yeah,
first
so
house was 4 bedrooms, 2.5 baths, with a 3/4 of an acre, a pond, a stream, and it was 32,500. So,
oh, beautiful.
yeah, it was pretty expensive. It cost me $273 a month. Yeah, remember, interest rates were 13% at the time.
I think ours was like 8% because I was newly minted in private practice, and they thought I was high risk.
Really?
Yeah, you chiropractors, you are all high risk. So
Yeah.
Well, chiros are the ones that do really well for themselves. That and dentists. Those are, if I had to do it over again, I
oh,
have a chiropractor friend in Indiana. She does 100 people a day at
mhm.
$65 cash practice.
Yeah.
She's making $6,500 a day, and she's on this large chiropractic management group. Grow your practice to $1 million practice. It's just
Oh,
this with a smile. My last manipulation is even better than my first. At the end of the day.
yeah. Well,
Wow.
Dr. Nario's going to integrative medicine school with Andrew Weil, and he's doing that. He's doing $6,500 a day also. Well, he might be spending
Thanks.
$6,500 a day.
Thanks for reminding me.
So Dr. Nario, so Chris, before we start, we usually get from Dr. Nario, what's the tip of the week for those of us who are too lazy or too cheap to go to integrative medicine school ourselves? We're getting the Cliff Notes version here every week. We learned not to ride a bicycle, like that was a big revelation. Well,
Well, right. Yeah, be afraid of bicycles. That's what I say. But yeah, you ready for the tip of the week?
ready for the tip of the week?
Yes.
All right. So there's so just to give you a background, Dr. Chris, that Dr. Weil focuses more of natural, integrative, none of these new peptide stem cells. So he's really back to basics type of approach. So one of his big passion are herbs. So currently, a study on Nutrients 2024 is a journal. The Washington State University trial. Actually, 18 overweight obese adults were the samples, and 12 ounces of elderberry juice daily for 1 week. Results were 24% lower blood glucose, 9% less insulin, 27% more fat oxidation, fat burning, post high carb meals, and at rest. So the thing here, it's really more like a weight loss supplement. And they also saw in gut health impact increases the beneficial gut bacteria, the Firmicutes, actinobacteria, decreased harmful bacteroides, basically a healthier gut and it's also reducing inflammation in these systems. So the mechanism of action, as they said, anthocyanins, anti-inflammatory, anti-diabetic, improves insulin sensitivity. The recommendation dose, 6 ounce of the juice, and the anthocyanins in 4 cups of blackberries. A very potent dose for, again, metabolic support. And that's why, again, we're all in this weight loss world nowadays. So this is one thing that's just that caught my attention. But of course, the sample side of this study was 18 people, and it was done in a short duration. But that's the good thing about that. 1 week in terms of assessment, they already saw weight loss in these subjects. But again, you cannot always bank it on supplements. There are always going to be confounders like exercise, lifestyle, and also side effects. Raw elderberries can cause nausea and diarrhea. So, but that's another tool that you can put in your weight loss arsenal.
Okay,
Detox.
So just to be clear, 6 ounces of elderberry juice a day, or more than once a day?
A day, 6 ounce a day.
That's not bad at all.
Not bad, right? So add it in your Dr. Bill. You have your weight loss.
Yeah, we'll add it. We'll add it in. We'll put it in with the apple cider vinegar.
Yeah, I'll tell Dr. Weil you've helped people with that advice.
Well,
today.
when you talk to Dr. Weil, in 2002, I was lecturing at the local conventional allopathic medical school, and there was an osteopathic considered alternative with the naturopaths and the chiropractors and the acupuncturists and the shamans. We were all considered CAM.
Shamans, yep.
And so what's interesting is Wendy Cahoot's a medical doctor, which was part of the NIH grant that we were participating in to educate the fourth year medical students. We all gave parting wisdom to the fourth year students. And so she started with, you folks probably were not told by your professors, but antibiotics don't work. That was her starting statement. Antibiotics do not work without a competent immune system. And so she gave an example of a full-blown AIDS patient, and that no matter what antibiotic, without an immune system, it wasn't going to work. My pearl was, we must all be perpetual learners. Would you each rather go to a person that graduated top of their class at some prestigious university but never learned anything over the last 20 years? Or would you like to have the middle of the class that was a perpetual learner? And remembering that you folks know more diagnostics and therapeutics than the people that sat in these chairs 5 years ago. The fields are advancing significantly, but you will become dated. And 5 years from now, they're going to feel you're the dinosaur unless you've continued to grow. That was my pearl. As a 34-year-old guy, that was my pearl.
I'll send the message out. He's
okay. But yeah, Wendy Kahutsu was an Andrew Weil graduate. So, and she was speaking like without an immune system, hey, I don't care what antibiotic you have. So yeah.
He's like
I knew him before he had his beard, and it's like Samson without the beard. Without the beard, he was nothing. So
he's weaker.
Yeah.
He's kicking at 82. He's running around campus seeing patients. So
good for him.
Okay, Dr. Chris, you ready?
I am.
Okay, everybody, thank you for being here for our weekly get together. Tonight we have Dr. Chris Melitis. He's no stranger to us. He's been with us a couple of times before. He always brings us something very interesting and thought-provoking. He's a practicing nutritional and holistic family practice physician, international lecturer, and author of more than a dozen books and 200 national articles. He partners with some of the most well-respected companies in the industry, and he provides patients with quality natural supplements and equipment. In his own words, his primary mission in clinical care is to support healthy aging while helping patients overcome barriers to optimal health. Many patients and practitioners underestimate the profound consequences of losing lean body mass. That's really become a thing lately, hasn't it? I know Stefan's big into that. So we didn't hear much about that before the Ozempic age, really. After age 40, individuals lose 1 to 2% of muscle mass annually and 1.5 to 5% in strength annually. Muscle loss or sarcopenia is amplified with the widespread use of GLP-1 based weight loss protocols. While extremely effective for fat reduction, GLP-1s often accelerate muscle loss. Through evidence-based nutritional and supplement strategies, this is manageable. This webinar will equip you with the science-based clinical insights to better communicate the value of muscle-centric longevity with your patients. We explore muscle preservation health techniques to support systemic homeostasis, improve metabolic health, vascular, cognitive, and emotional health, and introduce a novel food-based compound that in clinical trials enhances muscle physiology and counteracts anabolic resistance. With that, just to let you know that we are eligible tonight for 2 CME credits, AMA Category 1, and I'll put the link in on how to get to it shortly. Unfortunately, the price went up to $50, not my doing. We don't actually get anything for the credits. So if you're interested in that, I'll put that in the chat. And Dr. Chris, the floor is yours. Thank you so much for being
thank
here.
you.
Always.
Thank you for the warm introduction, and thank you everyone for spending time with me. One of the big controversies, as we see in the peer review literature, is do GLP-1s truly cause excess muscle loss? And they say in some of the studies, well, no, there's no evidence of that. But I asked the question for our average patient coming into our clinical practice, are they well nourished to start with? They are generally overfed and undernourished, and hence sometimes the presentation of obesity along with other issues. So the question is, if all of a sudden with a GLP-1 or similar meds out there, because there's a litany of them now, including through compounding pharmacies that blend them, all of a sudden I'm eating the same diet, haven't changed that, so they haven't came to one of us, and now I'm just eating less, and I'm injecting myself, and I'm eating less of the poor quality food I started with. And we wonder, why would we lose muscle mass when we were probably malnourished to start with and marginally of a nutritional status? So opposed to looking at just a GLP-1, or as I point out, bariatric surgery, anytime we cut caloric intake, especially from poor quality foods, we're going to have a consequence. So we're going to talk about myokines, metabolic health, mental health, morbidity and mortality, and we'll even talk about getting a grip on life, and we'll chat about that. And a novel molecule. I am an independent educator for MyosMD. The molecule with 10 patents on it is called Fortotropin. See it on the right-hand upper corner. And I'm just a 1099 educator for them. I am not being paid for this presentation. Decreased serum myostatin levels. We know with obesity and disuse syndrome. So if we get an injury, we get a knee replacement, hip replacement, or we just become sedentary more than we already are, well, myostatin levels tend to rise. They also rise often with obesity. Then what we also know is Fortotropin has been shown to increase protein synthesis and decrease the markers of protein breakdown. And I'm also an independent educator for Niagen Bioscience, formerly known as Chromadex, the people that offer true Niagen or nicotinamide riboside. So when we think of muscular performance, and we just think of the human body, I don't know about you folks, but when I look at the human body, I still have that childhood wonderment of how in the world does this all work? So we got a brain, we got a cerebellum. Many of you now know that the cerebellum contains 70 to 80% of all the brain neurons in mass. So we think, oh, well, I'm very cerebral. And of course, we have our frontal cortex, but 70 to 80% are neuronal densities in our cerebellum. And we now know the cerebellum is critical for rote memory and many other functions beyond what we used to believe was merely, when I say merely, I say that tongue in cheek, proprioception and locomotion. So when we look at the muscle types, so of course we have cardiac muscle, we have skeletal muscle, we have smooth muscle. And I do promise you guys, this will not become a mitochondrial gratification guru lecture. But if you think about the density of the mitochondria within our muscles, and then all of a sudden, if you think about the citric acid Krebs cycle, TCA cycle, and well, we got foods, we got carbs, we got fats, and well, they all have to go down through that little citric acid cycle into electron transfer chain to make ATP. And it's like all of a sudden we're becoming more malnourished when we go on to a diet. And so, and once again, we're, I think, an overfed, undernourished society in general. So one of the questions I raised when I was giving a lecture in New York, probably about a decade ago, I had flown in at 11 p.m. at night. I had a 7 a.m. keynote speech to give, and I rolled out of bed, and I've never had a whole lot of hair, but I've been bald for a good period of time, so I got the Elmer Fudd hairdo. And I always make the self-deprecating joke. Okay, well, of course, I had to wake up early for you folks for the hairdo, but still, even here as I stand on the stage, it's 4 o'clock my time. My adrenal glands aren't fully on board yet. But I says, how many cells in my body? I asked the audience. I said, anybody can answer the question, but how many cells in my body have to be tired, or in your body have to be tired before we perceive the status of fatigue? And this is, I'm going to tell you about, this was a decade ago, genetics and epigenetics, and show you the peer review literature. That I feel very comfortable with. But I still don't know. And I've looked, how many cells in my body have to be like these folks before I'm tired or exhausted? And I then raised up my finger, index finger, I want to clarify that, and said, how many cells in my finger must hurt before I perceive pain? And I said, to make it even more complicated, I think we've all had that little mini splinter, the microscopic splinter you can barely see, or we've all had a paper cut. And often the little mini splinter or the paper cut hurts more than a large splinter or a big cut. So I said, we must all stay humble in what we know. So that was younger me, still lack of hair. So is it just low thyroid? Is it adrenal fatigue? Is it gonadal function? Is it sleep deprivation? Of course, sleep apnea is pervasive in today's world, part because of obesity, but also dentition has changed. The straight smile, the white smiles that used to exist a few decades ago are fading fast, and orthodontic work until recently was all about straight teeth, but not that wide smile to tongue ratio. And the question is, what's contributing to that fatigue? But ultimately, of course, it takes brain performance and it takes heart performance, but it takes mitochondrial function for us to circulate through our 60,000 miles of blood vessels. 100,000 times a day is our heartbeat, and of course our neuronal function. As we sit here, 20% of our oxygen, 20% of our glucose is going to our brain. And I give a very simple but silly but provocative example to my patients. I'm sitting across doing a consultation with a patient, and I will hold up my cell phone and I'll show them all my apps on a given page. I said, how good are my apps? If you think of my apps on my cell phone, like the DNA within a cell, so a fingernail cell, a skin cell, a hair cell, heart cell, whatever the cell might be, I said, that takes energy to run that app. But if you are at a cellular deficit, what happens is you have a glorified $1,000 paperweight or more. So once again, it's all about manifesting that genetic potential. And this is all preamble to our bigger conversation today. So skeletal muscle makes about 40% of our total body mass, metabolically active clearly. If we lose that skeletal muscle, we've lost our ability to maintain weight loss. So let's say we've lost X amount of weight, but now if we've compromised our metabolically active tissue, then all of a sudden those calories will come sticking to us back again, much like Velcro. And we also know that individuals over the age of 60 are classified in the lowest third of strength. We're 50% more likely to die of all causes of mortality than individuals with the upper third of strength. And I saw one of our good doctors that looks in a pretty good shape that was on a video a little while ago with their shirt off, and it's like, okay, it's all about muscle to a very large degree. And muscular strength is significantly and inversely associated with the risk of death of all causes, controlling for confounding variables, including cardiorespiratory fitness. And this is way back in 2008. This is not something which should surprise any of us, but it's been, in my opinion, been underrepresented in the medical literature. And being the good Greek as I am, 48% Greek, 48% German, and a little hodgepodge of the rest. But which creature has one voice, yet becomes four-footed, two-footed, and then three-footed? And many of you know there was an Egyptian sphinx, and there was also a Greek sphinx that protected the city of Thebes. And lo and behold, we know the answer is mankind or humankind. We crawl, we walk, and then we go to our three legs with a walking stick, or these days, 6 legs, because we have those little roller scooters with the stand-up scooters with the little tennis balls on the back wheels. So when we look at the sarcopenia and morbidity, mortality side of things, and just again, a little bit more into the current literature, we see age-related sarcopenia. Of course, there's hormonal factors, inflamed aging, mitochondrial dysfunction, excess weight, of course, contributes to the adipokines, which often battle the myokines. Yeah, but then there's also telomere attrition. It used to be like we really want to have long telomeres. Well, we want to have just right telomeres, the Goldilocks, too short, too long, probably both problematic for the peer review literature. So once again, the aging process becomes very challenging. When you see here the poor diet, well, malnutrition becomes something. And it becomes something because we're not maybe making as much hydrofluoric acid. Maybe our brush border enzymes within our small intestine aren't doing their job. And where if we were doing stool tests, our pancreatic elastase levels are low. And other factors that come along with this, including desensitization of our steroidal and thyroid receptors. So there's a proposal in the peer review literature that doing a hand grip strength should be a new vital sign in our office. So we do the pulse ox, we do the pulse, we do the blood pressure, we take a temp, but we should also do a grip strength. And the reason that's being proposed is hand grip strength that serves as a functional metric in assessing muscle function and overall physical capacity, and particularly relevant to aging population. Grip strength has an important connection to sarcopenia in total in the body. And as you can see in the bottom pink highlight area, several diseases have shown a correlation between low hand grip strength. Diabetes, cardiovascular disease, stroke, kidney disease, liver disease, and some cancers. And clearly, if we're also weaker, we're more likely to fall, and welcome to the broken hip and potentially pneumonia and other sequelae as well. So I'm a big fan of grip strength measurement in clinical practice, and it's good to see it's coming out in the peer review literature. This was a 2024 article that came out speaking to this. And on that same article, they looked at association of hand grip strength. And the reason I'm going to hand grip strength is something simple. It's a way to measure fairly consistent. We got a female, we got a male, we have a large male, we have a small male, we have a large female, we can kind of start categorizing how do they compare to their equivalent peers relative to age and gender and whatnot. So you can see association of hand grip strength, psychological health. Oh my goodness. Functional abilities, morbidity, hospitalization. If you have good hand grip strength, you're more likely to leave the hospital than if you don't have a good hand grip strength. Go figure. And then, of course, mortality. In box 2 out of that same peer-reviewed journal article, look at the morbidities that we have here. Of course, the diabetes, the metabolic syndrome, onwards, cancers, hypertension, liver disease. And then we see musculoskeletal problems, of course, low back pains. And there's an argument that I often share with my patients. If you argue with the muscles will always win. So you go in to get an adjustment, osteopathic or chiropractic adjustment, and your muscles are a hot mess. Good ICD-10 code, look up hot mess under ICD-10 code. And it's like, but you got to work on the musculoskeletal side of things. But when it comes to leaving the hospital and nutritional status, hand grip strength is a great measure. It's something novel in our clinical practice. It will give us some data sets. It will give us also an opportunity, in my mind, to engage our patients in the challenge. I want to see your overall strength improve. I'm going to continue to measure your hand grip strength. And let's pick 2 or 3 other things we see to also improve. So it's a great way with our patients loving to see data. They want to see a lab result. They want to see EKG. They want to see the imaging. Well, this is a great way they can measure their success and making a difference in their trajectory. So when we look at
okay. Dr. Melitis?
Yes?
Sorry, I was just asking you about the grip strength before you go to the other one. Is it because of it's practical, or is it in fact really better than other modalities like the get up and go test?
From that peer review article, which if you email me at naturalmedman@hotmail, I'll email you the journal article. They've looked at a review of the peer review literature, and they actually found that the hand grip strength was a good metric. Now, throwing baby out with the bathwater, so to speak, are there other great metrics as well? But it's one of those non-invasive, easy to do. While they're already sitting there getting their vitals done, the medical assistant or nurse can say grip the strength and to give us that data set as well. So it's easy. It's the simplicity of it's beautiful, and the fact that they've cross compared it to other metrics relative to comparison. So it's more of a convenient thing, and honestly, kind of fun. I mean, I know when I used to go to a chiropractor 15 years ago, I would go in and play with whatever tool he had out there before he came into the office. And I was gripping that thing one time and he said, wow, your grip strength is, and of course I was, he was surprised on how good my grip strength was. But my grip strength has diminished over the course of time. So I've seen that trajectory as well. So yeah.
All right. Thank you.
Thank you. Great question. So risk factors, and my disclaimer on that, I do not own any company that sells hand grip strength devices, on a sense of humor here. So we see the risk factors for lower skeletal muscle, the mitochondria, the hormonal side of things, and for male and female alike. I mean, all of a sudden, the female testosterone levels are dropping with menopause. The male testosterone levels often dropping as well with the changes as well. But then also we see changes in DHEA and other hormones, including thyroid, which we'll chat about. But the concept here with the muscle is that if we don't use it, we're going to lose it. So once again, welcome to the sedentary style. He might have been an Adonis at one point in time, and maybe he still is an Adonis under all that. But the reality is he's losing progress. A body in motion stays in motion, a body at rest stays at rest. And what happens if we end up with an injury? Then all of a sudden we might have been having tremendous momentum, and we've seen this in our patients over the years. They were doing great, and then they had that hip or the knee, or they had whatever intervention, maybe a knee replacement, a hip replacement. They never rehabilitated totally, and they lost their momentum. And we're going to talk today about how disuse syndrome increases myostatin, enhances anabolic resistance, and not anabolic steroidal resistance, but the application of amino acids within the muscle. And also, if you become critically ill. Right now, as we talk, my sister's in stage 4 breast cancer has metastasized to her liver. She has a 3.5 by 3.5 liver tumor, and she's allowed herself to become emaciated, not a judgment call. But we know that up to 41% of people that pass from cancer is actually from malnutrition. And now she has all the other sequelae of low albumin, high bilirubin, and other problems, obviously. But many of us are familiar with the concept of euthyroid sick syndrome. So euthyroid sick syndrome is your hospital. You had COVID, you have pneumonia, you go to the hospital for whatever. And tomorrow I do a lot of charity work for patients. And I'm going to be working with a woman that is actually 37 years old with both urinary as well as GI bleeding. Prothrombin times are little on the high side. Her calcium level is exceptionally low. She's at a 2.89 on her total red blood cell count, 7.9 hemoglobin. And then my later call is going to be on a woman with stage 4 lung cancer that has a 10-year-old little boy. So these people are ill. But during that illness, for any of us, what happens is they say up to 75% of people hospitalized have a euthyroid sick syndrome. This is important because whether you're sick ambulatory in the real world or in the nosocomial hospital-based environment, our thyroid can start seeing some problems. And when we become severely ill or calorie deprivation, one of the things that's not being discussed in the peer-reviewed literature, if you go into severe calorie restriction, does your body perceive there to be a hostile environment? The answer is yes. So the euthyroid sick syndrome is the total T3 and free T3 with a lower or normal T4 present and often normal or low TSH. But the T3 thyroid, as we know, because when we prescribe Cytomel, for example, versus levothyroxine or Synthroid, we're going to have, of course, a much lower dose of our T3 dosing than our T4 dosing, because T3 is 3 to 5 times stronger than T4. But so now we're seeing that we don't have that T3 activity. And later on in our presentation, we're going to see that T3 thyroid actually goes directly down to the mitochondrial DNA to tell it how quickly to work. And then in turn, what triggers our thyroid tissue to work? Well, it takes mitochondria, it takes energy. So the thyrocytes need the mitochondria, and the mitochondria need our thyrocytes to do the work and have peripheral conversion. So it's a very intriguing perspective, to say the least. And this also ties into often when we go on calorie restrictive diets, we see ourselves or our patients plateau. That's because we're going into conservation mode. We start with Patrick Swayze and Dirty Dancing today in conversation off a quote, but let's go to something also of my genre and era, Boo Boo and Yogi. So cartoons, Saturday morning cartoons. And what does Boo Boo and Yogi, what was their prime directive? Their prime directive is to find the picnic basket. And so if you think about it, we're either going to go from T4 to T3, where we preferentially want to go, or you can go T4 to reverse T3, and that's where a park ranger is. Not where you're going to score your picnic basket and get away with it. You want to be going towards T3. But inflammation, things like Zantac and H2 antagonists, and a myriad of other things on another presentation I give, actually causes it to go to reverse T3. And so does illness. Also being low in zinc, copper, and iron also causes natural preference to go to T3. So we start becoming more malnourished and we start ending with problems. So with that, you'll see here on the graphic, the T3 thyroid here in the red box in the diagram. And it's like, okay, well, that's going down to the mitochondrial DNA. Isn't it intriguing that our eukaryotic us and what was been postulated in literature, the prokaryotic mitochondria, however you want to look at that, they're working in synergy, and that's kind of an intriguing side of things. So once again, T3 enhances that ability for mitochondrial density, and if we're not doing a great job of converting the T4 to T3, or we're going wayward to reverse T3, then we have a problem. And I give the example of our brake pedal in our car as reverse T3. It's like having a typist that has no qualifications for typing. Put them in front of your computer or keyboard. Good luck on getting production. That's reverse T3. Whereas T3, of course, is one of the fastest typists around. It's going to get the job done. I share a lot of these stories with my patients, as you can only imagine. You'll see in the red box here, it says, warning, don't die from dieting. Sadly enough, I truly believe that's what happened with my sister. We were traveling with her and her boys, which are much younger than mine. And she was told she had a basal cell right on the edge of her nose. And so she had Googled it, as people do, some of us as well. And she said, they're going to peel back my nose. There's going to be a big scar. So she went on in her mind's eye, an anti-cancer diet. She went totally plant-based. She stopped all protein, all sugar, and started losing a massive amount of weight. She was 55 years old at the time, and she lost about 30 or 40 pounds in 2 months on this extreme diet to fight the cancer on her face, which eventually she had the Mo technique. It ended up being fine. She didn't have to have her nose peeled back. But a woman that had not had a period for over a year had 3 periods each month up to her diagnosis, which was 4 months later. So from no periods, totally menopausal for the year rule, she had 3 periods for 3 months consecutively, and then diagnosed with inflammatory breast cancer. So the question is, she was dieting with the concept of being healthy, as many people do. But what we're doing, as you can see here, is we're mobilizing, and the pros here, mobilizing lipophilic compounds stored in our body tissue. Chlorinated compounds, DDT. And we said, oh, DDT, that was banned in 1972. And well, yeah, but they're still finding DDE, the metabolite of DDT, at 3.8 times higher amount in Alzheimer's patients. And then we have, of course, our forever chemicals with extremely long half-lives. And once again, because we're always translating the science we know into English for our patients, I give the example of an old school feather duster with real feathers. Like, if you were to look at my desk, it'd be very embarrassing, and it's dusty. So I take a feather duster and I dust it off, and look at, there's no more dust on my desk. Well, I just went and made it systemic. I made it go to some other part of the room. And so when we're losing our fat and toxins and hormones that we stored in our adipose tissue, and we're already dealing with today's chemicals, can our body really handle the additional burden of yesteryear and yesterday along with today? And sadly enough, that was a big change for my sister, was that window of time. Coincidental, causation, correlation, no one will ever know, but food for thought. So with that, resistance training, they talked about minimal dosing. This was a 2024 article, and I am not an exercise physiologist, but when I come across this literature, and it's something better than nothing, I would argue some exercise is better than nothing. So if you're going to just sit and never get any walking or activity in, it'd be better to do something. So many individuals do not participate in resistance training and perceive lack of time as a barrier. So they say, well, what about the weekend warrior? What about? So single set resistance exercise, which minimizes a set number and session duration, is one of the multiple exercises performed beyond many times per week called snacks. So well, opposed to going to a refrigerator, well, I'm going to stop at my stationary bicycle, which I have in my room here, and so I'm going to do some exercise. Something's better than nothing, question mark. So it's kind of interesting that we meet our patients where they're at. Not everybody's going to commit to a long program, but I generally find when my patients do commit to exercise, they start feeling the difference, the myokines change, the inflammatory processes start improving, and they have more giddy up and go. And so on that same note, they concluded, we have not provided a recommendation for minimal dose exercise, but rather to continue to work on and maintaining strength in non-athletes. A current review focused on muscle strength as a key outcome because muscle strength correlates with mortality and other outcomes of health and fitness. Once again, 2024 article. Remember, the initial stuff that I was shared with was 2008. They're just further validating what we've known for a long time. If you're in good shape, you're probably more Jacqueline or something, more likely to do well long term. This is a preprint, not yet published in gastroenterology. And I've shared this with you because they're talking about how when we exercise in our muscle mass and the impact on the microbiome and GI health. And the graphic here does a beautiful job in my mind of capturing a healthier gut impacts our muscle. And at the same time, the muscle impacts our gut. Of course, we have the smooth muscle, peristalsis, and all that. But we have this whole correlation of feeding the body, and nothing works in isolation. We live in a world of conventional modern medicine of specialists for everything. We have the cardiologist, we have the electrophysiologist, different than a cardiologist in some ways. You work with both of them. You work with, of course, a nephrologist, along with your internal medicine doctor. But you talk to the ophthalmologist, which I have a patient right now post-cataract surgery, and she has a macular adhesion, vitreal adhesion, and the ophthalmologist is saying, I don't know what to do about it, but, well, she's also diabetic. She also got some thyroid issues. She's also got sleep apnea. She also has, but the ophthalmologist isn't interested or capable of reaching into any of those comorbid factors. So he says, we're in a wait and watch mode. If it gets worse, let me know. It's like, So to see the exercise gut connection, very important. We know about the gut brain connection, but also, of course, how short chain fatty acids, including butyrate, not only feed the, of course, colon and the TCA cycle, but also the muscle as well. So I just thought it'd be kind of interesting to share. And I have that preprint if someone wants to email me at naturalmed, MEDMAN, @hotmail.com. So we have bariatric surgery, we have rapid weight loss. It doesn't matter what the source is. We can pick on GLP-1, but it serves no purpose. It's just merely a symptom of what's coming here. We have, of course, the concept of lowering myostatin and enhancing protein synthesis with a fertilized egg that's never been exposed to heat. It has 10 patents on it. Dialing back anabolic resistance and, of course, skeletal muscle influences. So now on the anabolic resistance, we think, well, that's anabolic steroids, no? And like testosterone, DHEA. No, it's actually the fact that our muscles no longer can actually take up things like leucine or isoleucine or valine as well. And there's a dysfunction at the cellular level. And particularly leucine comes up a lot with anabolic resistance, that if you were to supplement something, you might want to consider doing something like the phototropin along with some leucine or branching amino acids in concert, along with, of course, I have in front of me a balanced amino acid as well. So can you dieting? Yes, you can. We also know that if you ever have a female that's looking to get pregnant, they recommend never have her lose, not that we have control as healthcare providers, but do not encourage her to lose more than 5 pounds within 6 months, because otherwise what's happened is you mobilize toxins and chemicals, which then are airborne or waterborne, fluid-borne, body fluid-borne, right before you plant a zygote and grow it. So they're finding literature that if you lose a whole lot of weight before gaining baby weight, you actually can do a disservice for your outcome. So rapid weight loss increases muscle loss. no question about it, because once again, very few people are properly nourished to start with. So could you go on a GLP-1 or a bariatric approach to things and not lose muscle mass? Of course, yeah, you exercise, but most people that do these things may not be fully committed to that. Otherwise, often, but not always, they could have avoided those interventions. Preservation of muscle mass leads to a higher metabolic rate and maintains insulin sensitivity. So once again, muscles, of course, important. And once again, if we diet and we're only eating the modest amount to start with, and that's a healthy choice compared to a Big Mac or something. And this is interesting. This was in the peer review literature speaking about it, but it was also on healthline.com. And so this New York endocrinologist is quoted here. Sarcopenia affects the elderly population, typically is associated with aging. True. However, rapidly losing weight with GLP-1s like Ozempic and Wegovy without proper diet and exercise can also cause sarcopenia, sometimes referred to as skinny fat, at any age, negatively affecting a person's quality of life by reducing their stamina and ability to perform daily activities, such as easily walking upstairs, per Dr. Kimura, practicing endocrinologist. Seems evident, seems obvious, and that's where we come in. We offer to, hey, you can do this if you choose to do this because it might jumpstart you, but let's make sure we're keeping you strong and leave you better, not worse from the process. I just had a patient in Texas, a husband and a wife I've known forever in the healthcare field, and she's lost 91 pounds in 6 months with an injection approach to life, and he's lost 42 pounds in that same period of time. And so in their cases, they were actually supporting detox of phase 1, phase 2, phase 3 of liver, glutathione levels onwards and onwards, as well as taking care of their mitochondria. So reduce skeletal muscle, poor quality of life, physical disability, frailty, chronic disease, and it becomes a vicious catch-22. Now, what's also interesting is, of course, as we're all getting older, especially for the female patient, but also for the male, especially if he's andropausal, and I've had plenty of gentlemen that have had prostate cancer surgery, and they've gone on anti-androgens, and their bone mass starts going down, and because they don't have that anabolic larger amount of testosterone. So now imagine the woman here, or maybe it's a man, but it looks like a woman, and she starts losing weight. So if she only walks and she's not exercising and running or jogging, is she doing the same weight-bearing exercise she did when she was a heavier person? No, now she's a lighter person, so she's going to bear less weight unless she starts doing some activity that creates that bone density aspect of things. So once again, if you're going to lose weight, does she need to put on a weight vest to have that same amount of weight-bearing exercise she did before? It's just a philosophical question. I don't have an answer for you, but it kind of makes sense that, well, this person bared more weight. Now, of course, if you also bore weight, that can cause lordosis and other problems as well, but that's a whole nother conversation. So when we look here at the sarcopenia, there's also a direct link with Alzheimer's disease. So Alzheimer's and sarcopenia and vice versa, and it causes a whole cascade when we start becoming more sarcopenic of course, neuroinflammatory processes and other things like that. And then we start looking at reducing myostatin. So when you reduce myostatin, remembering the myostatin, if you have an animal model of a myostatin that is a myostatin inhibited, so there's no myostatin, high levels of myostatin, you're going to have a muscle-bound hamster, a muscle-bound bull, and there's actually a famous weightlifter, and he was world's strongest man, Eddie Hall. Eddie Hall, if you're familiar with world's strongest man, has lifted the most deadlift of any human known to humankind. But he actually says, I don't ever use enhancing perform things. I have a myostatin defect, and I don't produce a whole lot of myostatin. So he's naturally stronger as a result of lower myostatin. Higher the myostatin, the lower the muscle mass, and the less your returns in the gym, all things being equal. So myostatin inhibits muscle growth. So once again, we don't want to have a large amount. Obese people have higher levels. Disuse syndrome, higher levels. So being sedentary lifestyle, higher levels, all things being equal, unless you're Eddie Hall or a said-like person, has received a lot of attention. Deletion of myostatin in mice led to this secretion of irisin and the browning of white fat. So you want to brown your white fat and burn it into brown fat. Well, once again, lowering the myostatin is important. So by building muscle, you get that benefit, but also by lowering the myostatin, and the phototropin we're going to discuss today has actually been shown to do exactly that, lower myostatin that's elevated. So trigger alert, only for those that love biochemistry. And you say, oh, that's nothing, Chris. Look at that. Big deal. We don't know all of these things. Well, okay. Well, the trigger alert comes here. The complexity of the human body. And to think that all of these things are occurring unbeknownst to us. And of course, we know some of these pathways. We don't know other pathways. And we look at mTOR, we look at IGF-1, maybe a major growth hormone. We got vitamin D, which you think vitamin D, well, one of the antithesis of vitamin D is heavy metals. So if you're actually running along the busy highways and byways, the heavy metals can actually poison your vitamin D production. Go figure that. It's not from soot on your skin. Interesting article. So, but this is the biochemistry that's occurring with sarcopenic obesity. And it's like, wow, okay, so we're starting to have some interesting things out of Nutrients 2023. So I love to see the biochemical pathways as we currently know them, and because it gives us a aha moment. And so we're looking to lose weight. Our patients are looking to lose weight or support healthy weight. And the process of heat production, there's numerous mitochondria containing uncoupled protein, UCP1, allowing them to generate heat by burning calories, and the browning of our fat. And how do we brown our white fat cells? Cold exposure. Welcome to the plunge, cold plunge. Certain hormones like irisin. Once again, if you decrease your myostatin, you can improve your irisin levels. Norepinephrine and specific exercises. Thermogenesis. Once again, that whole process of burning the calories and burning the brown fat. And obesity and weight loss. Browning a white fat may promote weight loss by increasing the body's ability to burn calories. Of course, duh. And so with that, that's a 101 discussion of the browning of fat. But once again, you need to have your mitochondria at play here. So the phototropin is a fertilized raw egg. It's lyophilized, it's freeze-dried. And it has 10 patents on it. And it's been shown to increase protein synthesis, decrease protein breakdown, and help reduce myostatin levels. And so myostatin is an important therapeutic target because it's involved in several disorders, including diabetes. So your diabetic and metabolic syndrome people, individuals have higher myostatin levels most often. And various clinical trials using myostatin neutralizing compounds and antibodies have been shown to improve muscle homeostasis and metabolic disease. And myostatin works as a negative regulator of muscle growth. So the higher the myostatin, the less muscle growth. So you want to inhibit the myostatin to a healthier normal level. And normal levels, let's call it the 1970s body type or the Italian beach type that still persists to this day, whereas we, of course, see so much obesity. And myostatin and protein levels are increased in skeletal muscle and plasma levels for obese, insulin-resistant individuals, whereas the decrease of myostatin improves insulin sensitivity and reduces obesity. So much like the elderberry, 6 ounces a day, why not use food as our medicine? And eggs are food. And so if we think about the pharmaceuticals and things which we can do, yeah, they're there. And if we're not doing the natural things and natural things aren't working, yes, thank goodness we have our prescription pads. I got mine. I have my DEA number. I flex it when I need to flex it, but I try to avoid it when I don't need to, because with every great and powerful biochemical intervention comes, of course, a potential ripple of side effects. So maybe some elderberry and some myostatin inhibition with raw fertilized egg. So the studies on the peer-reviewed literature of the phototropin are as such, and I'll be more than glad to send these to you. They're also available on the last slide. There will be a link to all the science, but the research is quite compelling. Myostatin reduces protein synthesis. Okay, so we want to inhibit the myostatin. It rises with age. Well, welcome to age-related sarcopenia. And so the breaking of the dysfunction of the myostatin cycle is very, very important. So in study of younger, middle-aged, and older men, serum myostatin levels increase with age. That's a known fact. The study also indicated that myostatin levels are the highest in physically frail older women, and that the higher the skeletal muscle mass, the lower the myostatin levels. So let's get in shape. Easier said than done, especially if you have an elevated myostatin. But if you can take a product like the active ingredient corticotropin, along with all the other things we as individual providers might recommend for them, might we actually help them break out of that sticky cycle of where they're at. Researchers reported in the Journal of Gerontology, myostatin inhibition provides a promising means to attenuate or reverse skeletal muscle loss in the context of sarcopenia, as well as cachexia, disease-associated muscle loss, and to enhance skeletal muscle regeneration in the context of congenital diseases such as muscular dystrophy and injury. I'm right now working with a group of 5,900 individuals with Duchenne's and Becker's muscular dystrophy. It's a social media page, trying to get them to apply this in their potential complex medical interventions to help improve outcomes for those people suffering. I'm worked with a little boy, which is now 17. He has Duchenne's, and he has not done this Duchenne's muscular dystrophy protocol of steroids and all of these things, glucocorticosteroids, prednisone, and whatnot. He's gone au naturel on mitochondrial support, muscle protocol that we've put him on, and yet he finally got wheelchair bound in age of 16. He has a chair that lets him stand and do all this, but he started losing quality of life because he needed people to help him potty and also to shower. So we put him on the corticotropin product, and he's actually able to he regained the ability to do those things by himself. And when people that I knew the family would come by on the rare occasion, they noticed he was more toned and fit and less, my word, scrawny looking. So it's kind of interesting. Once again, small print, individual results will vary, but if it's merely giving a fertilized raw egg product, that's like, wow, worst things could happen unless you have an egg allergy. Then of course we have a bigger problem. So the effects of corticotropin supplementation on body composition in a human trial of 37 resistance trained college athletes mean body mass significantly increased in patients given corticotropin. And then we see that they were either given 6.6 grams or 19.8 grams. Those with a higher amount experienced greater improvement, but both groups experienced improvement. And they found the corticotropin decreased markers of protein breakdown. And the group that was taking, both of them, actually had a significant increase of muscle thickness. Then we see the human clinical study investigation of 21 days on corticotropin supplementation. So in merely 21 days of taking this egg protein, the randomized placebo-controlled double-blind study of 20 participants found that the average protein synthesis of corticotropin increased by 18% compared to the placebo. Interesting. And the study indicated that corticotropin has the potential of managing age-related muscle sarcopenia. For me, when I look at a fact like this, I'm thinking, okay, well, all my patients that have chosen without me to do GLP-1, because that's something I don't feel that I want to be involved in. But I'm saying at least do things that are going to help maintain your lean body mass so that you're strong and lean on the way out, opposed to lean in terms of weight on the scale, but lean also on muscle. I want that active metabolic tissue. So the research is that stimulating muscle protein synthesis in elderly patients could have potential of increasing body mass. And that's obviously another duh. So then they looked at dogs. And these happen to be dogs of veterinarians. So these veterinarians said, okay, well, my dogs are going for the equivalent of a knee replacement, and I want to see what happens on corticotropin. And so in contrast, the placebo-treated group experienced an increase in myostatin levels. Remember, myostatin levels increase with disuse syndrome, hip replacement, knee replacement, immobilization, sedentary lifestyle. The dogs given corticotropin also experienced no change in thigh circumference. Okay, so there was no change, while the placebo group had a reduction in thigh circumference. So the dogs went in and they maintained their thigh circumference. The dogs that didn't get a corticotropin atrophied. We've all had disuse syndrome. I just got over a frozen shoulder, which I was dealing with for 7 months. And boy, was I losing size in my arm and strength. Once again, disuse syndrome. What happens when we have it in a sling? Disuse syndrome. So we also look at the decrease of myostatin and the concept of if we lessen myostatin levels, we can do it with corticotropin. There's small molecules and peptides and drugs they're looking at. Exercise, resistance training has also been shown to reduce myostatin. Now, can you imagine some resistance training with somebody with Fortotropin? Once again, I'm an independent educator. I have no dog in the fight or horse in the race, but ensuring quality protein intake, of course, makes sense. The Fortotropin is not particularly high in protein, so it's not, well, that's how it's working. It's high on proteins. No, not at all. But they also found that particularly leucine, in addition to the Fortotropin, can also be beneficial. And so when we see the myostatin levels increase with age, and we see all these changes occurring with the lack of activity, once again, thinking of the riddle of the Sphinx. And we've seen all these changes occurring, but we're also seeing an increase in myostatin the moment we get older, heavier, and or more inactive. And so what's interesting here with the aging process, we see that sarcopenia, decreased mass, of course, but then we see here mitochondrial DNA mutations, lower number of mitochondria. And we also see impaired biogenesis and mitobiogenesis, the creation of mitochondria. So this is where you think PQQ, pyroquinone, along with your CoQ10 and all these other favorite things that we like to do. I will point out also in another lecture that I give, there's a list of drugs that poison the mitochondria. Propofol is one of them. General anesthesia is another one. Lidocaine, going to the dentist a little too often to make friends and influence people and drool publicly, could also cause problems. And so there's all these meds that we're potentially prescribing or taking or procedures we're having, and we're like, my candle's not as bright and as light as it used to be. Maybe I need new batteries. Once again, that's the mitochondria. So the Fortotropin, once again, not going to speak a whole lot about it. It's just an egg-based product. And it looks like that coming out of cancer. I got some here for myself. And out of the California Berkeley University, Dr. William Evans, you might be familiar, he goes around the country lecturing on sarcopenia and muscle mass. And he was a principal on this study. At the time, there's 8 US patents. It's increased now to 10 and 6 successful clinical trials. There's 2 or 3 more happening. I'm hoping what occurs from our little unofficial Duchenne's Becker project is that we see what kind of dosing is optimal, and then we can do a larger muscular dystrophy component to things as well. And so anabolic resistance, not to take too much time on this topic, but once again, we look at high anabolic resistance, obesity, sedentary lifestyle, and we want to lower that. So we want to lower that anabolic resistance. And so a healthy person that's aging is okay on anabolic resistance. A heavier person that's aging, not so much. And this is a 2021 article. So once again, allowing the muscles themselves to take up the amino acids that maintain their optimal homeostasis opposed to a marginal homeostasis. And we see here also controlling the myostatin and the involvement of all these lovely little hormones, some of which we measure. We know decreased testosterone, male and female alike. That's why in my clinical practice, this is when I do flex my prescription pad, doing some bioidentical hormone for females also often will include a little testosterone. And looking at the oxytocin levels, also interesting because that's used a lot with autism and people with psychosocial separation, anxiety, and so forth. Some nasal spray, oxytocin can be good. And so we're looking here at, how do we help these hormonal sides of things so that knowing that the lower your muscle mass, the greater your mortality, all things being equal. So there's a catch-22. Skeletal muscle insensitivity to normal stimulatory effects of amino acids. That's anabolic resistance. So once again, you can throw in some anabolic, hormones, but we're talking about anabolic resistance that you just can't take up the amino acids like we could, which becomes a catch-22. And then we see the skeletal muscle influence on homeostasis. It's like, wow, it's talking to everything. So if I keep on keeping my biceps and my hamstrings and my quads strong, like, wow, and my glutes strong, it's like, it's going to have a positive impact on potentially everything. So that's a strong consideration for why we want to stay strong. Plus, we want to stay independent as well. But it has a ripple effect, a domino effect throughout our body. And they did a study way back in 1953. And yes, I found a double-decker bus in the United Kingdom from 1953 because that's when these 2 Lancet articles were published. So I said, I got to find a 1953 bus. So I did. Hippocrates guided his theory of balanced humors, advocating that absolutely every young or old person needs exercise, but not too much. And so a study in 1953 looked at the drivers of public trolleys in London, and they had twice as much coronary artery syndrome than those that were the conductors, because the conductors had to walk around and collect the tickets. The driver sat there all day. Interesting. So way back in 1953, they're like, why are these drivers all kicking the bucket and our conductors are outliving them? Is that kind of interesting? I thought it was interesting. Putting our muscles to work, and once again, asking the question of how do we help with that sarcopenia? How do we help with that process? And of course, it takes ATP, takes absorption through our GI tract. So let's say a person's taking a proton pump inhibitor or an H2 antagonist, something to block the acid, which is so terrible for the human body, tongue in cheek there. But so now all of a sudden we have to do the protonics, we have to do the Nexium, they have an ulcer in their stomach, and we're trying to help to heal the process. But they stay on a long term. Are they going to absorb their proteins as well? No. So once again, an independent risk factor for our patients. Like when they come to us, well, how did they get to their broken state? That's a question we ask all the time. So how did you get here? Well, what drugs have you been on? And I ask the same question about what drugs have you been on that are on my mitochondrial poisoning list, because that's important as well. So if I was to be lazy, which at times I am, I would choose to be this fellow. He doesn't have to go get the ice from the convenience store. He doesn't have to plug in his ice bath. He just sits there, and clearly, as you can see, he's also grounded. Lots of mud on those feet. So you got grounding and the ice plunge. And of course, we know that the cold plunge is, of course, helping for mitogenesis. So, of course, we have our skeletal muscle. And once again, I'm going to make all these slides available because I think they're fun slides. I enjoy putting slide decks together. And it's like, okay, well, look at all these things. And this is what we're doing. And we want to help with IGF-1, and IGF-1's low. And in fact, about 50% of my patients are in the mid 50s to 60s. Their IGF-1 levels are abysmal. And then they have elevated cortisol levels, which of course we know are catabolic. And so we are losing the battle on anabolism versus catabolism. And remember, an elevated myostatin decreases irisin. So you want to reduce the myostatin to improve the irisin, which also has anti-inflammatory effects. So muscle to brain again. Gotta love it. And we have the exerkines, which are basically just myokines. Discovered in 2000 that muscle contractions release interleukin-6. I used to think interleukin-6 was just terrible. If I couldn't find it on a C-reactive protein, I couldn't find it on a SED rate, and there's no positive ANA, I'm saying, I bet the interleukin-6 is causing the problem. That was my mindset for a few years back in the day. And they're finding out exerkines help release the response for both acute and chronic stress and exert a paracrine and autocrine pathways, and they improve cardiovascular, metabolic, immunological processes. So once again, but how do you get exerkines? Well, you got to exercise, and you got to have the muscle to do it. And so multitude of organs are affected by exerkines. And so we have the skeletal muscles, the myokines, the cardiokines, the hepatocytes, the adipokines from white fat tissue, cytokines from brown onwards. So the goal is here to help. And exerkines have a potential to treat cardiovascular disease, type 2 diabetes, mellitus, or mellitus. I should be able to pronounce that since my name is Melitis, and obesity, and possibly facilitate healthy aging. So my takeaway is a leading accelerator to muscle atrophy is reduced nerve innervation to target tissues. You got a lower back issue. Don't be surprised if you have neuropathy. You might have if it is really bad, bowel and bladder issues. If you have a mid-thoracic issue, you might have a T4 syndrome, as some people like to call it, which can affect cardiovascular performance and rhythm issues. Of course, we have the vagal nerve also playing a role on the parasympathetic, sympathetic side of things. But andropause, menopause, elevated cortisol, thyroid dysfunction, growth hormone deficits, all are at play here. Inflammation's a role here. And the anabolic resistance, age-related suppression of protein synthesis. Got to absorb the aminos. But once again, if you don't have the aminos in your diet and you're on a restrictive diet, bariatric or GLP-1 or any other fad diet out there, because after all, a diet should be the diet we're on to be well and not a diet just to lose weight. And so poor nutritional status, select medications, GI problems, and of course, dysbiosis come in. We all know that if a patient has diarrhea and we give them a prescription med, should we expect that prescription med to work well? No, it's running through their body quicker than not. So the classical pharmacokinetics and pharmacodynamics are not going to manifest because it's very rapid bowel transit time. Likewise, if a person had really slow bowels, and my record was for a patient on my typical intake form, I asked about GI health, regularity, and they put regular. But of course, I still go over the intake form. So to me, what regular is once or twice a day. And we had this conversation. And he says, no, it's very regular. I said, well, can you tell me more? Yeah, about every 3 weeks, I have a bowel movement. I wonder why they're feeling poopy. What happens? You get dry stool. What happened to all that moisture? That's poo water. It kind of makes someone feel poopy. There must be an ICD-10 code for that too. And so this one's a fun bonus. I came across this in preparing this presentation for us today, and they have found a link between tight hamstrings and the myofascial plane and decreased mobility and articulation of the cervical spine. Is that interesting? So effects of hamstring flexibility on cervical range of motion and deep neck flexure endurance in healthy young adults. So if you sit all day long and your hamstrings, okay, and your neck's forward, might that help a person not feel like their head's on straight? I think that explains most of the world. And I think we just solved the world's problems. Let's work on the hamstrings, pun intended. I just had to throw that in as a bonus. It's in the literature. So I have a 63-year-old woman. I put her on the phototropin. She had severe osteoporosis and sarcopenia. She was very underweight, very weak. She got on a ladder. The ladder and her fell on the ground. She shattered the entire right side of her body, her humerus, couple, 2-3 ribs, her hip, and they rebuilt her, Jamie Summers style, a bionic woman. So they rebuilt her, but she's dealt with severe osteoporosis and immobility as a result, and so we put her on the program. So then we have, of course, along with other protocols, 55-year-old pre and post surgical knee repair. He has 5 boys. He plays soccer. He's a Romanian fellow. He's very much into his European football. In fact, very wealthy guy. So he travels to Russia and other places around the world to watch the World Cup and so forth. But I put him on the phototropin pre and post surgically to help with realizing he's going to have a disuse syndrome for a while as he ambles along. 86-year-old. This gentleman is a physicist. His wife is a chemist. And they both walk about 10,000 steps a day. In fact, they're a hoot to chat with because she says at the top of the hill, I actually have to bend down with my device to get the elevation credit for doing the hill, because otherwise she wasn't getting the credit for having done a hill. He also, in his case, he's the one that fell. He fell on a slippery pavement in Oregon, and he became very challenged on ambulatory. His gait was just totally messed up. And this is a guy that on a daily basis would also do 50 flights of stairs in his house. He'd go up and down the stairs with intention 50 times as part of his exercises, kinesthetics. So we have put him on the phototropin to help him regain his benefits. 35-year-old actually happened to be a chiropractor. Went on GLP-1, not my patient, had severe sleep apnea, regained all his weight back, and yo-yo dieting, but he had lost a lot of his muscle mass as a result of that. So we put him on some phototropin. And then the Duchenne's little boy, which is now 17, we put him on phototropin. So this is my summary that I've created in my summary of the peer review literature as I see it. Muscular energetics and nutritional status, of course, got to make sure we got oxygen. If we got apnea, we got problems. And when I was 36 years old, I decided I was going to get in shape again, if I was only in that shape now. But I decided I was going to grab the 20-pound dumbbells from underneath my bed, which had a lot of dust on them. And I cranked out 100 reps in each arm. That was lightweight for me at the time. And I went to bed. The next morning, I could not stretch out my arm. My bicep was so tight and so painful. And I said, well, that's interesting. This is before I knew I had sleep apnea. So this is kind of the tell. So I decided, okay, I'm the dean at the Naturopathic University. I'm in charge of the moderate complex lab. I'm going to go, now that I'm getting healthy, my one time of lifting weights in a long time, I'm going to have a blood draw. My AST and ALT were both in the 400s. Back then, there was SGPT and SGOT. And I was like, so the head of the laboratory, she calls me. She was a thespian, that's an actress. And she says, Chris, are you sitting? She was a direct report to me. I said, okay, what's going on, Trish? She said, no, are you sitting? I said, why? And she says, we need to talk about your labs because we had a moderate complex lab. So we just ran that on our machine. She says, how you been feeling, Chris? I was like, why? Your liver enzymes are, she's dropped the ball in the mid 400s on both of them. I actually figured like, what the heck? So I went off, got an internist, didn't have one, got worked up. They tried to do LDH, lactate dehydrogenase isoenzymes. They misdrew it twice. So they didn't freeze it. And I'm thinking, okay, I'm dying of some terrible liver disease. But lo and behold, nothing came back from that and the other tests. And I went to a hepatologist. And I said, yeah, let me just do some research. Paralympic wheelchair athletes also have elevated liver enzymes from wheelchair racing. But what I did was I had bicep infarcts. I could still not stretch out my arm for 2 weeks. And back then it was briefcase era. So I would have a briefcase. No matter what I could do, I could not keep that bicep stretched out. So interesting, once again, oxygen. Lo and behold, I was diagnosed about 6 months later with a 65% oxygen level at night. Wonder why my muscles weren't happy after becoming engorged with the weightlifting. Sorry for the long story. You get the idea, though. We find humor in sometimes our own little journeys. So from a GI perspective, clearly the things we want to improve on the right-hand side. From a psychological, physiological stress perspective, adaptogen is very important. And then from a brain neuromuscular perspective, got to get the rest. Got to make sure our epi, norepi, and acetylcholine. So once again, I do a lot of those kind of tests in my clinical practice. And this little poster I created is, of course, readily available to anybody that wants it. I'm sure it can be improved. So successful muscle retention with optimized weight, mitigating anabolic resistance by inhibiting myostatin. And also, it's been shown that fortotropin enhances healthy mTOR levels in skeletal muscle, consuming sufficient calories to prevent the increase of T3 to reverse T3 conversion. And that's the euthyroid 6 syndrome. And then we have sufficient protein and essential amino acids. Mitochondrial NAD and R. I'm a fan of NR. From my last presentation, I know there's various thoughts on that. CoQ10, PQQ, resveratrol. Exercise, steps, and resistance training. I tell my patients, get an app on their phone and track their steps. And I pay 29 cents a day, TMI, to have my phone guilt me on my successes and failures on getting my steps. It stopped harassing me. It's at 7,400 steps. I wasn't doing 7,400 steps enough. So now it just has left me on 7,400 steps and hasn't caused me to go higher on my steps. Detoxification to support the liberation of fat soluble toxins. Any single thing about losing weight, you got to support phase 1, phase 2, and phase 3 detox. It's another little chart I've created. More than glad to share it with you. It speaks to the nutrients necessary for phase 1 and phase 2 and phase 3's urinary and fecal elimination. And then, of course, quality and quantity of life, rule out sleep apnea. My patients often have high deductibles. And so I send them to a company called Lofta, LOFTA.com. I do not work for that company. For $189, they will get a sleep specialist to not only conduct the test at their, remotely, they'll send them the kit out of Israel. It's the technology. They telemetrically get the data and voila, we'll get a diagnosis and if necessary, a prescription for an apnea machine or dental device. My big thing for muscle health, minimum, of course, along with CBC and a comp metabolic and all the basics, is make sure they're not diabetic. Make sure there's not a diurnal rhythm issue with cortisol too high, too low. Clearly, we know that the human body on a normal basis makes about 20 milligrams of hydrocortisone a day. Cortisone to cortisol go back and forth in terms of interchange of the molecules. But if you have a low hydrocortisone level, aka low cortisol levels diurnally, you're going to have some breakthrough inflammation. You're going to want to either do an adaptogen or some hydrocortisone to buffer that. DHEA, we know that with the aging process, whether it be lab or Quest or whomever we use, they lower the expectation for DHEA to be age adjusted while you're allowed to be a little bit more broken. Or if you're on an elderly cruise ship, they're not going to lower the limbo stick too low because people aren't going to be able to get underneath the limbo stick. So I like to keep DHEA a little higher for my patients in the age adjusted range of more broken or more acceptable. Total free testosterone. And of course, looking at, and for females, I'll do also sex hormone binding globulin specifically. And then looking at the thyroid, including reverse, and then the growth hormone. So the phototropin, and my last slide here is I've been long-winded. The proposed mechanism from the 6 studies is it decreases serum myostatin levels, which is elevated with diabetes, typically elevated with disuse syndrome, elevated with obesity. It helps with protein synthesis. Remember, the 21 days, 18% increase in protein synthesis, decreased markers of protein breakdown. This is a good thing. A couple of the references there, but once again, I can provide the references. Or once again, I'm an independent contractor, not being paid for this presentation. I just love you folks. You folks do great work, and you have the heart of any good society. You folks have it. I mean that sincerely. So, but if you want more information, the head strategist for the company, he can provide you all the research, or I can too, at naturalmedman@hotmail.com. So I'm open for questions. I probably won't know the answers, but I'll try my best. Everybody left. My feelings are hurt.
No, that was a good presentation, Dr. Chris.
No, we're all here for you. Anybody have any?
We're all lifting weights right now.
Yeah.
Cool.
So I have a question here, Chris. How does this compare to follistatin 344 injectable peptide?
Yeah, this is of course a food-based product, less invasive. The side effect of this product is it's an egg, and if you're allergic to egg, that's a problem. Otherwise, it's just a fertilized, raw, lyophilized, freeze-dried egg with patents on it. So I can't make a comparison because one's a drug and one's a food. That would be like, how does the elderberry 6 ounces? Thank you, Doc, for sharing that. I'm going to tell a lot of people that. So thank you for imparting that. How does that compare to metformin or glipizide? Give me the elderberry with also the anthocyanidins, glucosylceramide, and whatnot. So yeah, I go Andrew Weil on this one. So I would just say if you can do it naturally without injections, but clearly you can do injections. I mean, but I'm least invasive to most invasive. Recently, I sent a person off for an ultrasound because she was having gastrointestinal discomfort. She's an 86-year-old Navy vet, and she was in the brass, so to speak, as she calls it. You know, she was up in the ranks back when there was not even something called a glass ceiling, but she broke through all the glass ceilings. She was an officer, and so she's having GI pain. And so I'm saying, well, let's get an ultrasound, let's get some basics. And the technician sent her home and says, your doctor ordered the wrong test. Well, I know she's had hernia surgery. I know she has adhesions. I know she had. So I was looking for other things too, but thank you for doing my job for me. Clearly, I could have done a CT from the ribs all the way down to the pubic symphysis as the technician told her she needed. But I said, yeah, wouldn't it be nice to start without all that radiation? So yeah, I say start with the least invasive, and we can always go more complex. So, but that's my touche on that. So I don't have an answer otherwise.
All right. There is a question about, are there any peptides you do recommend?
I like the BCP 157. I just got acquainted with a company that's providing it at a very affordable price, and I don't know whether we're still in our CME or not. But I can provide that information whenever we're not CME oriented.
I'll let you know when.
Okay.
So,
but yeah, so I like the BCP. I think it's BCP 157. Yeah, it's been a long day, and I'm dealing with trying to arrange the funeral for my sister with the liver cancer. So,
okay, Dr. Nario, do you have any questions online?
Yes. So one of the things I think they're asking So you mentioned about GLP-1s. What is the good way to integrate this to the protocol? Like in terms of maybe frequency, duration?
Yeah, so for my patients are doing the GLP-1s, I'm making sure they're taking a good multivitamin, they're supporting their mitochondria, they're doing some sort of amino acid blend. I happen to have one in front of me here, and I'm not doing a GLP-1. And I also have my Fortotropin branded item in front of me. Just so I'm doing on the Fortotropin, my patients will do anywhere from the 11.6 to the 19.8 as their dosage. The little guy that's 108 pounds now, was a 13-year-old at the time. He with a Duchenne's muscular dystrophy, we actually have him on 3 times that dose because heroic times, heroic efforts. Because obviously Duchenne's is otherwise fatal condition, so we're kind of going after it. But typically, the 19.8 is plenty of us find us. That's a scoop and a half per day, along with all the other aminos and so forth. Because it is an egg-based product, it is not water soluble. So most people put it in like a little Greek yogurt or something. So my wife doesn't like yogurt, so she says, "Can I put it in pudding?" And she's recovering from her diabetes. I've been in the 300s for the longest time. She finally allowed me to intervene as her husband, and so we've got her now with a fasting glucose of about 116, 111 in the morning. Before she was in the 300s, and her A1C was up to 12.8. So she's lost a lot of muscle mass as a result of that. So we're actually, she was not on my list there, but we've implemented this for her as well.
So you mentioned that's one of the questions. So it seems like you can mix this with food.
Yeah. Oh, without a question. Just can't cook it. Cannot cook. It has to stay in the raw form for the Fortotropin to stay in structurally active. But yeah, as long as it's mixed with something that's not cooked, not a problem.
Okay. Yeah,
some people put it in their protein smoothie.
Okay, that's even better then. Yeah, some questions here are about how you give it, interaction, side effects to keep an eye out for. Do you have any of those information on hand?
Side effects, you said?
Yeah, side effects. How do you take it? How often?
Yeah, so just once a day. Just once a day. Well, I mean, in the case of the little boy with the Duchenne's, he was doing it 3 times a day. But everybody else is just doing it once a day. And 19.8 grams. So which is a scoop and a half per day, and just once a day. And as the study showed, within 21 days, there was a tremendous improvement in protein synthesis, and people are noticing the difference physically on their performance and so forth. Now, could you add it to creatine? Could you add it to other things that you might feel are enhancing it? Yeah, there's no contraindication. The only contraindication, if you can't tolerate eggs, don't eat it. Just like I wouldn't recommend peanut butter to a peanut butter allergy person.
Also, egg allergies definitely off the table.
Yeah, egg allergies off the table.
Okay, gotcha.
Otherwise, we're going to have bigger problems.
Yeah, because you mentioned about this is interesting about grip strength, right? You mentioned about another supplement company is actually advocating for this, and I'm sure you're familiar with this. It's not. I'm not going to mention the name. It's actually Urolithin A, and so that's actually something that they get from pomegranate seeds, and this is something I guess metabolized by your microbiome, and this is also their kind of claim to fame about increasing grip strength. The thing with that though is they're saying there that it's one of their parameters that they use, but they're using other parameters in terms of muscle strength as well to assess the effectivity of their product. So, but the thing is with the question of grip strength, how do you test yours? I know they use this grip machine or grip scale. Is that something that you also have used in your clinical practice?
And so I've presented on pomegranate, and particularly a specific kind of pomegranate, which is more readily converted through the GI tract than other pomegranate, because the problem is it has a healthy enough GI microbiome to convert ellagic acid in. And punocollagen specifically has good research showing fairly easy conversion. But as we all know, there's a product out on the marketplace which is purified, highly bioavailable urolithin A preformed, which is also used. I use just a dynamometer like this for grip strength in my clinical practice.
Oh, okay. Yeah, that I think I've seen, but there's a digital one also. I think that.
Oh, there, and that this one's a $300 one. The ones on off Amazon, very affordable. I mean, like
Yeah. Are they
40 or
comparable?
$50.
Are they comparable though?
Yeah, I mean they have reproducibility, and so then it's all about, are you using it for yourself or are you using it for part of the dog and pony show? And
All
so,
right.
yeah,
Yeah. Well, I
and
saw
I
that.
can tell you, even on this one, which I've used personally before, it's a little harder to grip. It's not quite as user friendly as some of the less expensive ones. This one, even I will cause my knuckles to pop and crack when gripping it.
All right, right. Well, that makes for sure. That's gonna make your hands like go bigger in no time. One thing here is irisin stimulated by any other way other than exercise?
Exercise and lowering myostatin levels are the two big ways that I'm aware of, and
Mhm.
and I'm a Whitman sampler. I know many things about a lot of things, but very little about anything in great depth.
Right.
I give between 15 and 30 lectures a year where I become a content expert in passing. I'm being
Right.
honest and humble. I'm trying to be humble.
Yeah, well, I don't know if the supplements kind of hit the mark. I just remember, but there are very weak studies also, like taurine, for example, has that ability, and even creatine, but I haven't heard much really in terms of strength and how they are able to increase irisin that much. So,
Yeah.
but yeah,
Yeah. And so the whole concept here is, by, as you can see on the last sentence here, deletion of myostatin and mice led to secretion of irisin. So we're not wanting to delete myostatin, otherwise we'd be so muscle bound we could never button our shirts. And if you
sure.
looked up myostatin inhibited animals, they look like, you know, comic book cartoons. They're just muscle upon muscle upon muscle. So I find the exercise and the phototropin are the ways I've intervened, but once again, that's just an N of one.
Right, right. And you showed also a slide here about, of course, I think you were talking about ice therapy, ice bath therapies and also grounding. Are there any, I guess, studies that proves that this actually helps irisin and myostatin?
The ice therapy in particular helps with the mitobiogenesis. I can't speak to that with any level of confidence that I would want to be quoted.
So it's more of really you're promoting that as an adjunct therapy along with
Yes.
with the
Yes.
yeah with the other things that you mentioned.
Well, I mean, for me, because I love our little mitochondria. It's all about, for me, supporting the mitochondrial pathways, because it's our for real, light bulb. The flashlight turns on or flashlight turns off. And so
Right.
most of us are somewhat corroded, like old batteries in a transistor radio, and we're just trying to improve things.
All right. I think yeah, those are my questions, and I think everybody's ready for you to unveil the product and how we can get a hold of it.
All right.
Those are some of the
Thank
questions here too.
you, Dr. Chris. Thank you, everybody.